Good evening and welcome to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram, and tonight we have two fascinating cases on the theme of women's health. Discussing the first case tonight, we have our panel of experts consisting of Dr. Kathy James, our rural GP and medical educator with QRME. We have Dr. Anthony Cerqui, who's a specialist obstetrician and gynaecologist from St Andrew's Private Hospital here in Toowoomba, and Marissa Bertello, psychologist with Milne Street Mental Health. And they're all practicing here in Toowoomba. Please welcome our specialist and expert panellists. As usual, we are being live streamed around Australia tonight. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au, or you can tweet your questions using the hashtag now on your screen. Our presenter tonight for our first case is Dr. Nazik Itaiwi, and she will be presenting cases of women with Lichen Sclerosus. Please put your hands together for Nazik.
All right, my case today is about Lichen Sclerosus. Not very common disease in women's health, but maybe that's because it was missed by some GPs or by doctors. I'm going to present 4 of the cases that I've seen in my clinic in the last 2 years. Quite interesting cases, so bear with me. Case number 1 is Mrs. JB. Mrs. JB is a 62-year-old recently retired nurse. She used to be a nurse at the mental health. Presented as a new patient to my clinic for just general checkup after her retirement. As a routine question about preventative health, usually asked about last pap smear, and she was overdue for her pap smear as her last one was 8 years ago. She was a widow, so no sexual activity for the past years, as she said. Past medical history, hypertension, otherwise unremarkable, and so we organized pap smear to be done in the next visit. When she came the next visit on inspection, I could see advanced lichen sclerosis of the vulva. It was very uncomfortable and painful for the patient to proceed with the speculum examination. Actually, she started bleeding from the area, so we just stopped the examination as she didn't want to go further, and we didn't do the pap smear. So the first presentation basically incidental finding with asymptomatic patient, but it was painful to do speculum and pap smear. Case number 2, Miss S.E. She's a 54-year-old female. Presented for pap smear as her GP was unable to perform one for her, and she was due for one. She was sexually active. She told me with the questioning that she has dyspareunia and causing her marital problems with her partner. She had 2 children, both were normal deliveries before. And on examination, it was not very bad lichen sclerosis, but there were some areas which was affected in the labia minora. I could do the pap smear for her. Case number 3, Mrs. MS. She's 87-year-old lady. She's a nursing home patient. I saw her just because her GP was away, so I just looked after her while he was on leave. She had basically a history of recurrent resistant UTI, and she was put on prophylactic antibiotic. She told me with the questioning that she's very itchy down below, and she was treated by her usual GP so many times for thrush with just mild response. When I did the examination for her, it was very advanced lichen sclerosis. The anatomy was almost disturbed there, and vaginal opening almost obliterated. There was no signs of vaginal discharge or thrush at all with this lady. My fourth case is a 72-year-old lady. She presented basically because of symptoms of the usual symptoms of lichen sclerosus, which is very itchy and sore in the vulva. She felt shy to talk to her GP because he was her GP for the past 30 years, and he's a male GP. He has been treating her for thrush, and she had some temporary response, but the condition was there. And on examination, she had lichen sclerosus also around her labia minora. So this is what the lichen sclerosus look like. I got some photos from Google, so if you would like to see more photos, just Google them. And this is another presentation, and you can see the lichen sclerosus around the labia. So what is lichen sclerosus? Lichen sclerosus is a benign condition. It's a chronic and it's a progressive dermatological condition. It's characterized by marked inflammation with epithelial lining and distinctive dermal changes. It's accompanied by symptoms of pruritus and pain. So usually the patient will come and say, I'm itchy down below and I'm sore down below, and it resembles thrush actually. The etiology is unknown, so as simple as this, you tell the patient when they're going to ask you about it, it's unknown. Different mechanisms are there. Some of them, they say genetic factors. Some people, they say local factors, and there was an interesting study that I would like you to know. It's really interesting. So the study showed that when they take a skin graft from the labia and put it on the thigh, the lichen sclerosus disappeared. And when they take skin grafts from the thigh and put it on the vulva, the lichen sclerosus happened there. So it was really interesting to know. Another mechanism, it's immunological abnormality, hormonal factors, infection with a special kind of bacteria, and also human papilloma virus have an etiological factor there, and some cell kinetics. Signs and symptoms, so completely asymptomatic, as in my first patient. Vulvar pruritus, as in my fourth patient. Pruritus ani, so they present just like hemorrhoid when they have the itch there. Painful defecation, anal fissures, and rectal bleeding. Dyspareunia, as in my second patient. Dysuria and difficulty voiding, as in my third patient. So you can see I've tried to cover all the spectrum. I've seen more of these cases also in the practice. What you see in the examination, it's white atrophic papules that may coalesce into plaques. Hemorrhagic, purpuric, hyperkeratotic, bullous, eroded, ulcerated, so it's different presentation. Most frequently affected the labia minora and or the labia majora. Lesions of the genitocrural folds, thighs, and buttocks are common. I haven't seen them before with my patient though. Fissuring is frequently seen perianally in the intralabial folds or around the clitoris, and excoriation from the scratching, basically. As the disease progresses, the distinction between the labia majora and labia minora is lost, and this is what I saw in my third patient. At the end stage of lichen sclerosus, the vulva is featureless due to midline fusion, which leaves only a posterior pinhole orifices. That's why with my third patient, I told the nurses at the nursing home, if this patient ends with a mass in her tummy, that's her full bladder, and she cannot wee, so you have to stick catheter for her or call for help. Extragenital lesion could happen in the thighs, breasts, wrists, shoulders, neck, and rarely the oral cavity. These lesions are not as pruritic as the genital lesion. What should we do as investigation? Basically, it's biopsy. So you have to confirm with biopsy. It's about 3 millimeter vulvar punch biopsy. And biopsy should not be taken from a woman who had been treated with steroid within the previous 2 weeks. You need to do also some blood tests to exclude other autoimmune disease like diabetes, thyroid, and pernicious anemia. And we need to do high vaginal swab to exclude if it is a thrush or bacterial infection. Differential diagnosis, so lichen simplex, vitiligo, pemphigoid, anal fissure, hemorrhoids, vulvovaginal candidiasis, which is maybe the most one would put it against our condition, psoriasis, and premature ovarian failure. What's the treatment? Basically, steroid. So steroid is with betamethasone 0.05% ointment topically each night for 4 weeks. Then every second night for 4 to 8 weeks, depends on the severity. And then twice a week for a long-term maintenance, with return to more frequent administration if they have flare-up of their symptoms. Symptom control is usually achieved within the first 1 month of the therapy, but complete return to objective clinical normality is not usually achieved. No place for vulvectomy in the management, and surgical correction of effusion and stenosis may be indicated, and that's only in severe cases. Follow-up. So there is increased risk of developing squamous cell carcinoma of the vulva. So those patients, they need a good follow-up every 6 months for indefinite period for carcinoma surveillance. What happened to my cases? So the first patient, she declined referral. She was really in pain after we've done the speculum. I started her on Ovastin cream and steroid cream, and I lost the follow-up with her as I was in maternity leave. My second patient, the Pap smear showed some low-grade changes, and I referred her to Tumba Hospital for a follow-up of both condition and in case they want to perform biopsy. My third case, I just referred her back basically to her GP because he's back from his leave, and he was not very keen to refer her as technically was difficult. She was a bedridden patient. And my fourth lady, I referred her to a private gynaecologist. She had a private health insurance. He did a biopsy for her, and which showed and confirmed lichen sclerosus. He started her on some steroid locally, and she found, she returned back to see me a month later, and she was very happy that she found an answer for her prolonged illness, which has been there for years with no definite treatment. I had some questions and concerns for my patients. So my first question to the panel, do we need to do biopsy for all the lesions to confirm the diagnosis all the time? And my second question, can we start the treatment on basis of suspicion of the condition, or we need to do the biopsy to confirm the diagnosis first, especially if it is technically difficult like my third patient? And my third question was how long we should treat for, putting in mind all the side effect, even if it's just local steroid therapy. And my fourth question was the follow-up. Can it be done by the GP, or it should be by specialist? And this is my references, just simple references there. Thank you.
Very much, Nazik. So if we'd like to perhaps start with some of those questions, if that's all right. I might open with you, Dr. Izza, if that's all right. Sorry, I'm sorry, I just sort of dozing in. I do apologise. But yes, just as the specialist, to comment on sort of about the issue of biopsy, particularly in these cases where it can be quite sort of, I guess, painful for these ladies, and how important is the biopsy, I guess, in confirming diagnosis?
Sure. I think with these ladies, it's very important to get their confidence. If they come in and the first thing you do is poke them with something sharp, as one of your ladies, they're going to run away. Mm-hmm. So I think if you genuinely have a high index of suspicion that you're dealing with something more than uncomplicated lichen sclerosus, you'd be wise to send those patients on for further assessment. When I see them, it's rare that I'll actually biopsy them in the rooms, because even using local anaesthetic, it's extremely uncomfortable in that area. And so I think, in part, your initial decision, you've got to make some assessment. Does this look nasty or not? And I think if it doesn't look nasty, and your presentation, by the way, was great, and the cases where it's obviously mild, I think it's quite reasonable to give a course of steroids. And within about 6 weeks, you'll get an idea of whether those patients can just continue with that. But as you said, there are risks of an underlying SCC or progression to SCC, And if there are lesions there that aren't healing with steroid or look suspicious, you really do need to biopsy them, but in an appropriate setting.
Great. And if I can ask you, Kathy, as a rural GP, is this a sort of condition that you see quite commonly? How often do you think a condition like this would present to your clinic?
I think it's really quite an unusual condition, but having more information about lichen sclerosus, I do wonder sometimes, looking back over my 20 years of general practice, I wonder how many times I might have seen it and not recognised it actually in my earlier years. One of the things that the presentation actually brought up for me was the importance of actually looking when people come and present with these vague complaints of it's itchy down below or on the lips, or, you know, well, what actually is it and where is it? And I think it's really important that we actually look early to see what people are presenting with. And also the vulva is a complex structure, and we don't often have good names to describe what the different parts are. So it's an opportunity, if you have a mirror in the practice, you can get the mirror out, ask the woman to have a look and show you exactly where she might be getting the symptoms if there's no obvious lesions there. So I think that would be my first comment about the presentation. I'd agree with Anthony about the treatment. Using high-dose steroids early on is really important to relieve symptoms, and also I think slows down the progression of the longer-term sequelae of the condition. I don't think I would biopsy myself. I'd probably be referring to the specialist for those reasons of, you know, being uncomfortable. Just as an aside, the importance of steroid therapy, you're using the most potent of the steroids, and it's really important that the patients are instructed to use the smallest amount and applied just to the area that has the lesions. It doesn't need to be smeared generously around the whole area. It's just applied, and a 30-gram tube of the steroid cream would probably last a woman 6 months to a year. So I think it's really good to give people who are using steroid cream a really good indication about how much they should be using and how often. And I think the importance of using it daily to get on top of the symptoms, and then back titrating the dose to a smaller maintenance level that keeps the symptoms at bay.
So, is there any sort of ballpark time frame that you would expect then? I think there was a question from Nazik about how long should we be treating women with steroids. Would you give them strips and send them away and I'll see you in, 3 months? Or would you be getting them back sooner? And how long before you sort of think, am I not winning? either
I think one of the risks is actually undertreating them. And I think patients get terrified as soon as you say, just put a little bit of this on. And invariably my experience is they're not putting enough on. I agree with you, Karen, that there are risks of... Kathy, sorry. That's all right, I'm Dr. Esler. You can there can be risks of atrophy, but in reality, a patient with really severe vulval lichen sclerosus, atrophy is the least of their problem. And I think you're wiser actually to hit them hard with steroid. And my kind of catch cry to them is pulse therapy. So if it flares up, really hit it hard for 6 weeks, every day, just hit it, and then go back to a maintenance dose. And the maintenance dose may involve changing over to a weaker steroid, just a hydrocortisone. And I have some people that are using hydrocortisone after they've done the pulse for 3, 4, 5, 6 months. And, that's, even if it does thin a little bit, it's a lot better than really nasty lichen sclerosus.
I think the follow-up is important, you know, to see, and I think the GP can do it, would be my feeling. And you'd be seeing how their response was to the treatment, so you could monitor how much or how little they were using. But I think the other thing in terms of just one other sort of issue that came to mind when we were talking about vulval itching is not to forget to ask patients what they are using to wash themselves with as well, because you get some really interesting feedback about people, you know, scrubbing the vulval area very vigorously and using all sorts of highly perfumed products, which can, you know, cause a lot of other problems like eczemas and dermatitis as well. So when you're taking the history, don't forget not only to really inspect the area and think broadly about what it can be, but to also ask what actually the woman is using to clean the vulval area. And really the vagina is self-cleaning, and probably just water and the runoff of soapy water which comes down from washing the body is all that you need.
Thank you. And Cerqui, if we can ask sort of another sort of angle on this. I mean, it sounds like a number of these cases actually presented quite late, and there was an issue of embarrassment and not wanting to raise it with a GP they were familiar with, you know, for a long time, or with a male GP and that sort of thing. For the registrars who are watching tonight, sort of what kind of advice would you give them as a rural GP, sort of in trying to help the patients to feel comfortable opening up and talking about these sorts of embarrassing conditions?
I think probably being respectful, and if people are coming with recurrent conditions that aren't clearing up, being quite comfortable about offering to examine and making sure that the woman is in a private and feeling comfortable, it's nice and warm, you know, and not being frightened to have a look and explain what you're doing. And I think that having more information and more knowledge that the woman can have, I think that lessens the embarrassment as well. And part of the examination and using the mirror is that you're actually giving the woman feedback about what the areas and structures are that you are looking at, and asking her to identify where there's the issue and putting a name to the area. You know, so it just helps empower her a bit by giving her the language to describe what's going on.
Great. And do you think that there's, you know, a role obviously we do for involving sort of allied health in psychologists and that sort of thing, particularly in cases like the ones presented where there was sort of marital constraints and dyspareunia and that sort of thing that can sort of impact on relationships?
Oh, definitely. I think a condition like lichen sclerosus, where you can actually get quite a lot of you know, even the actual sort of coming together and fusing of the labia minora, you know, that can cause a huge amount of difficulty. And I think, you know, if someone is having sexual issues, I think referring someone early on is the way to go. And not just on their own, but with their partner as well, is a consideration.
And if those sorts of things are happening, I think there is a role for very early surgical intervention, just breaking down some of those labial adhesions, because as soon as I've had ladies come in and they've presented with, I spray my urine, I don't have a good stream. And basically they've just occluded the urethra. And as soon as you start showering that area in urine as well, that's just makes it all worse. So, you know, I think really have a good look and just check that the basic anatomies are normal, because it's very easy to break down a labial adhesion in about 2 seconds under an anaesthetic, and they get relief.
Fantastic, yeah. So what other times would you say that surgery would sort of be indicated? Is that sort of the main reason why you would take a woman into the theatre, or before you mentioned biopsy? Is there any other things that...
Yeah, I think the indications would be biopsy and wide local excision if you're really concerned about an abnormal area. As I said, breaking down adhesions and just trying to restore a normal anatomy around the urethral meatus. I think also it does have a role for some of the ladies with dyspareunia, because you do get a lot of atrophy and scarring, and sometimes a simple Fenton's procedure where you just enlarge the introitus, it's not going to get rid of the condition, but it does provide some relief. And then if after you've done that, you hit them hard with steroids, you know, it's a chronic condition, we've acknowledged that, and you may give them 12 months relief or 2 years relief. But if you've been in a terrible situation where for the last 5 years you haven't been able to have intercourse, or you're in pain every time your husband or whoever comes near you, you know, that bit of relief is a welcome thing.
Absolutely. Thank you very much for your insights. So I might ask Marissa if you'd like to make some comments as well about if a patient comes to you with an embarrassing sort of condition, particularly, you know, if it's a lady affecting her genital kind of area, what sort of approach you would take in that sort of instance in your clinic as a psychologist?
Well, I think, as Dr. Cerqui said, to make sure that you build a very good rapport with somebody before you start to do any work. I think it's really important not to over-pathologise anyone just because they have a medical condition that quite possibly had normal mental health prior to that, and they might not have anything. So we talk about potentially traumatic events, not traumatic events, because it depends on the person. So I would be expecting individuals to have, everyone's different. So I think the one thing that I got out of this was potentially the shame around being such a private area, being something that not wanting to discuss. And so creating a safe environment for that person to be able to discuss their symptoms and the genuine impacts that they're having, so that we can then set some goals to try and overcome or help them to integrate, you know, or repair relationships.
Would you often do therapy with the couple to involve the partner as well, if that was something that the woman was interested in doing?
If that was something that she was interested in, I think that first of all I'd need to make her feel very comfortable. Yeah. Sometimes she might present with her husband, so they might be very close but just not able to navigate this particular situation. So that would depend on the client, and I'd be open to it if that was what the client wanted, because I think that gives us an opportunity to help them to communicate in a more effective way. So obviously communication's going to be an issue, and expectations as well. So that capacity for them to learn some different ways of talking with each other, that could be very helpful.
Fantastic, yeah. And I was just going to point out sort of a number of these cases seem to be sort of a more common sort of in menopausal women or postmenopausal women. Is there sort of commonalities or other sort of issues that we should be thinking about with some of these patients? So maybe if I start with Kathy, if you can sort of comment a bit more about sort of women that have presented to you, maybe have something like this, like lichen sclerosus, but what other sort of things should we be doing for them when they've presented with this kind of an issue, if they're menopausal or postmenopausal?
I just think in terms of menopause and postmenopausal women, I mean, it could be a combination of lichen sclerosus, or it could just be an atrophic vaginitis, in which case, you know, the combination which you used, one of the patients using some Ovestin cream. I think in terms of general support, I think it's just giving people good information and responding to their needs, and especially around relationship issues. Early referral, and as Anthony said, if there's real issues around sexual dysfunction and it's very problematic, early referral to the specialist, so that you can get a second opinion and some good follow-up from the specialist services as well.
Fantastic. So just with discussing referral, for a registrar seeing a patient with something and they think, oh, this could be lichen sclerosus, and they weren't perhaps sure how to manage, what kind of things would you look for in a referral from a GP to help to educate the registrars as to what they should be including in a referral to yourself, and or sort of any workup that you might want to have seen before they make it to you?
Sure. I think all of the basics have to be performed. So it's important, if there is an excess pain, to ensure you've done a pap smear, to ensure that you've taken a swab. It could just be thrush that hasn't been adequately treated. In younger people, certainly a sexual history, and look for any, you know, bacterial pathogens, any bacterial vaginosis, those sorts of things. I believe in terms of the basic workup, they're the important ones. I think once the diagnosis is established, and if you've decided to take a biopsy, or particularly in a rural setting, you know, you may have access to day surgery with a colleague will give an anaesthetic, or even sedation. I think once you've established the diagnosis, the other autoimmune things that Nazik mentioned, you know, excluding the pernicious anemia, the diabetes, the thyroid problems. All of those sorts of things are important.
Okay, excellent. And so I don't know if we can sort of digress a little bit more sort of about just talking in general rather than specifically about lichen sclerosus, but more in general about sort of disorders affecting sort of the genitalia. Maybe if we can branch into things like vaginal atrophy and things like that in menopausal women. Is there any sort of other sort of things that you'd like registrars to know for managing these sort of patients in particularly rural general practice?
Yeah, I think vaginal oestrogen gets forgotten so often, and I think there's such a fear out there now about using HRT that estrogen gets forgotten, and it's amazing how much a difference just using Ovestin every night for 3 or 4 weeks can make. And I think that would be my number one message. Well, 2 messages. Firstly, look. If you don't look, you're always going to make a mistake and you're going to miss things. Secondly, do the basic tests. And thirdly, don't be afraid to use Ovestin vaginally and to use steroid creams. And if you're not getting a response to your steroid creams and those simple measures, then refer on and get it looked at more closely.
Fantastic.
Can I ask you how long you'd recommend women be on the Ovestin cream for?
Look, forever.
It's an indefinite treatment that can be safely used.
You just keep going for as long as you need it. And, obviously involve women in their decision-making processes. What's the incidence of breast cancer? 1 in 9. I've had patients that we've used Ovestin on, and 2 years later they've come back with breast cancer. And, I doubt very much the Ovestin caused it. They were going to be that 1 in 9. But, talking to them, their quality of life and things like that have to be considered. And, I think you just say, well, you need to continue doing all your normal well-woman checks.
So, can I just ask if women have had, if they've had breast cancer and maybe they've, gone through recovery and sort of 5, 7 years later, is it still safe to use Ovestin cream in that situation?
I believe it is if they need it. Because you have to look at quality of life. But obviously you're telling those ladies, look, you keep doing your normal checks, your normal breast follow-up.
Yeah, the reason I ask is I had a situation where there was someone who'd had a previous breast cancer and then had quite severe atrophic vaginitis with recurrent urine infections. And the recurrent urine infections were the things that were being treated, but actually the real problem was the atrophic vaginitis. So we had this discussion about the fact that it was probably unlikely that it would cause a problem. But, like you said, to have the ongoing checks with the mammograms and things like that. Right. But she elected to use the Ovestin cream with really good results, and then her urinary tract infection stopped and she felt a lot more comfortable.
And I think titrating it to effect's important as well. You don't have to stay on the same dose for 6 months. You can hit it hard for a couple of weeks and then back it off. And she knows when she has to increase it again once she starts getting symptoms again.
Yeah, this is a very important point, I think, as well for registrars. I believe there is a current set of guidelines by, I think it's from the RSCGP, but it may actually have been RANSCOG that have done guidelines about use of HRT in menopause based on all of the information now sort of post WHO, and then my understanding from my last reading of that was that it is very low risk to have vaginal oestrogen and that there's virtually no contraindications to it. So that sort of reinforces what I think you guys have been saying. But I encourage registers obviously to do their reading and to check up on that. It's a massive document from my memory that went into all the different risk groups. I don't know if you remember, Nazik.
If you read the MEMS, they will give you all the contraindication for the Ovestin that you cannot use it with any women. Like, for example, it is okay to use Ovestin cream with breastfeeding moms when they have atrophic vaginitis and dyspareunia. But if you go and read the contraindication, one of the contraindications is breastfeeding. And that's why sometimes it's difficult. Like you tell the patient, it says it is contraindicated, but it's safe to use. So it's a matter of negotiating sometimes with the patient and advise them about the risk and benefits.
I think that's a common problem with MIMS. It often says that things are contraindicated when in fact They are not. These are great questions. I might start to throw it open to the studio audience if there's any sort of burning questions there in the audience that anyone would like to ask of our specialist and expert panels.
Excuse me, I thought I'd start with a comment. I actually assisted with I'm a nurse, in the GP practice a couple of weeks ago, and there was a very elderly lady. She was in her late 80s and having a vaginal examination and was amazingly mortified by the whole thing. And the young registrar was amazed that she was so embarrassed. But as I explained to him, these were the women who delivered in the days of the stirrups and the screen. You know, they've always had sex in the dark, and they've never actually watched anyone looking at them before. So if you are, actually, having to do a vaginal examination in an elderly lady, sometimes I think you have to offer them, that over-the-top sort of, privacy. So, and just remember that it is a totally different generation. You are dealing with women who are, have had no contact, with any private parts, and that's the way they'd like to keep it. So, you are facing 70, 80 years of absolute outrage. So, just for the young ones.
Thanks very much.
It's an interesting point, if I could just add about that. If you are doing examinations in older women, and if it is clear that the woman has atrophic vaginitis or to insert a speculum is difficult, I think it's better just to not proceed and give the woman some treatment with Ovestin cream, and it's often just a few weeks treatment, and then ask the person to come back, and then you can actually much more easily do the examination. And I entirely agree with you about the sensitivity around dealing with older women and the fear of embarrassment, and I think that's really important that we are sensitive to that.
Hi. I actually have a question. It's a bit of a follow-up on that, and that is one of your cases, I think you mentioned the patient's regular GP was male and they were reluctant to discuss any women's health issues, and I know this comes up quite a bit where you have, and understandably, you have issues in terms of gender preferences for general practitioners, especially in rural areas where you may be the only doctor in town, or there may only be male GPs available. And this would go for anyone. How would you go about developing that rapport properly and broaching that topic, and therefore engaging women in things like preventive health, being able and willing to consent to being examined if they have a problem such as this? It's something that comes up a lot, and it's just not... I don't quite know how I would deal with it, so if anyone has any comments, that'd be great.
I think if you're in a practice where you know you're going to be there for a while, the trick is to get in early. And meaning somebody comes in, you've got to be careful how you approach it, obviously, but they come in and they've got a cough, and you're dealing with that, and I think you get in early and you say, oh, look, I know your pap smear is coming up, we should start to think about that, and, just plant the seed rather than just lob it on her when she turns up one day, or, just so she's had time to come to terms with it.
Yeah, I think, having your own confidence and being comfortable about doing examinations, and be experienced, so get as much practice as you can, and then when you come to the examination, you're good at doing it. So I think it's not a reason to put it off, the fact that there's a gender difference, and being sensitive to the person's feelings. I know where I work, there is a women's clinic that's run by nurses, so that there is some choice that the women have. So in a rural area, they can come and see a male GP, they can see a female GP, or they can see the female nurse. So I think having some choice is a good thing as well. If you're male, I think it's really important that you consider having a chaperone. As for all of us, we should be checking and having chaperones, but I think particularly for male doctors and in remote areas. Yeah. Does that answer your question?
I think another very, very, very important thing, if you're going to make the investment in providing that health service, you have to make sure you're set up to do it properly. Right? So there's no point getting somebody into your room not having the right light, not having the right bed, not having the right speculum, not having lubricant, and then expecting that it's going to be a great event, because it isn't. It's going to end in disaster. So I think it's really important to make sure you've got everything just right and, plan for it.
I think that's a really good point there too about the right equipment, and I think that just reminded me of something in my training, just being taught to have everything ready and set up before you get started in the procedure, because there's nothing worse than getting halfway through something and reaching for something and realising it's not on your tray ready to go. That can just be very awkward. And I think the other message I was going to say is I think it can be hard for us as registrars, I think, to because we often are coming into the practice and are there for a year, and then we move on to another practice, and trying to lobby for that equipment that we feel comfortable with. And I think when you go to a practice early on, sort of identify where your equipment is, what you have available, and getting used to sort of using it, maybe even do a little mock sort of pull it all out and check that you can use it quite comfortably. And if there's issues, then raise that with your supervisors, because there's, like you were saying, there's nothing worse than getting ready to do it and realising that you're ill-equipped or ill-prepared.
And I think the other thing, like if it's a preventative health, so when you ask the patient like about their pap smears or if they have any problems, it's a way of asking, as Kathy said, more than, or Dr. Cerqui said, rather than waiting for them to tell you. And if they tell you like hint of the thing and you feel that they are uncomfortable with you because of the gender issue, just offer a referral for another general practitioner in the same clinic, or to family planning, or to the specialist who they might feel a bit more comfortable with them. With my patient, she was, because her GP was her GP for 30 years, and because she really was in a good relationship with him, she felt shy to talk about her private parts with him. That's why actually she used to live rural, so she's one of the rural patients, and came to Toomba, and 3 hours driving, searching for another female doctor to check that area. So that's why I mentioned this in my case, because I think this is one of the things that leads to misdiagnosis or forgetting about lichen sclerosus.
I think the other thing that you will be checked out if you're working in rural practice, that you will be visited and tested a little bit, and the bush telegraph is incredibly efficient, and so within minutes virtually the community will know kind of where you stand on these issues. So if one person has a good experience, it just spreads like wildfire and people will come back. So I think that's important. If you're new to an area, just be relaxed and be yourself and be open, and bring up the issue early. In sexual health, when I was working in a population of very young people, I'd have a bowl of condoms on the desk, and it was just, help yourself, and that was a great segue into STI screening, and then talking about what other sexual health issues and what relationship issues they have. So there are ways of kind of giving people clues and hints that you're comfortable about certain topics and certain ways of examining people. Yeah.
I think the other thing too, I'm just thinking about the aged female client, especially the one who's coming back with recurrent thrush, and people and they'll come and they'll tell you this is the symptoms. You think, okay, you got thrush. Is that I think that in Australia we don't expect women to have fistulas anymore. And once again, you think it's a third world problem. It's there are women out there who have undiagnosed fistulas, and you only find them when you've been working in a nursing home, and they've had this. They must have had it for 30 years, 40 years. Never, would never consent to an examination, and but kept getting treated for recurrent thrush. It's something that needs to be considered as well.
Fantastic. I think we've got time for one or two more questions. If anyone's got anything that they want to ask of our expert or specialist panel. Yeah.
No question, but could I just amplify Anthony's point that you've got to have the right equipment, and there are big specula, small specula, wide ones, thin ones. you need all of them because there are all these different size and shape vaginas. But there is no excuse for using a speculum that hasn't been warmed up. You should never insert a cold speculum. No excuse for that. And you can make a big song and dance about it in front of the patient to say, I am now warming up the speculum, or alternately, I've already pre-warmed it. And it takes a lot of the tension out of the equation because they're expecting something not so good anyway, but if it's a really cold, not so good something, they really don't like it.
Fantastic point.
And having done 3 years in country general practice, I endorse those feelings exactly that. You just hold your ground, you be who you are, and you'll be right. And when they want to go to the big city to have a smear, it's often because it's the only way they can get their husband to drive them down to the big city to go shopping. So just say yes. Don't fight it.
All right. Well, I think that's all that we have time for this afternoon, unless there's one more question that anyone's desperate to get in before we wrap up today. All right. Well, thank you very much to Nazik for her excellent presentation.
Thank you.
And thank you to our specialist and expert panel tonight for their very valuable discussion regarding this fascinating condition. So we can all please thank our panellists.